Shoulder examination by Professor Hatem Galal Saeed. We will be looking at the shoulder by inspection, palpation, range of motion, and special tests. With special testing, we look for certain pathologies like impingement, rotator cuff pathology, AC joint pathology, biceps pathology, slap lesions, and labral lesions, and instability. In inspection, we start looking at the patient from the front. We look at the shape of the shoulder and the deltoid muscle. Like in this example, you see this man has axillary nerve palsy with deltoid wasting and square shoulder. Then we inspect the shoulder from the back. We look at the contour of the muscles, the supraspinatus and the infraspinatus. We can see in this example, this man has wasting of the infraspinatus muscle on the left side. In palpation, we are going to look for the AC joint, the anterolateral shoulder, the biceps tendon, and the coracoid. We start the palpation anterolaterally to see if there is any impingement, and then we move on to the AC joint where there is a slight depression between the acromion and the clavicle. We look for local tenderness. And then we move downwards about 1 inch to see the biceps tendon. When the arm is facing forward, we can actually palpate the biceps in the bicipital groove. Once that is painful, we do internal rotation, and this becomes non-painful. This indicates local biceps tendonitis. For range of motion, we do flexion up to 180 degrees, and we also do abduction up to 180 degrees. External rotation with the elbow at the side, range roughly between 70 to 90 degrees. From the back, with inspection, we also look at the scapulothoracic rhythm to see if there is any scapular dyskinesia or winging. This is very common with any mild shoulder problem. For external rotation, we also view the position of the arm behind the head. And for internal rotation, we see the arm reaching T5 on the dorsal spine. For impingement test, we look for the Hawkins test. We flex the elbow forward 90 degrees, and then we do internal rotation. This elicits pain in cases of subacromial impingement. We also test for abduction external rotation, which is limited with severe impingement and quite painful. Examination of the rotator cuff will go according to the muscle examination. So for subscapularis tears, if it's a complete tear, there is an increase in passive external rotation compared to the other side. We also ask the patient to push internally, do internal rotation against resistance, and test for pain for the subscapularis. If there is pain, then we might do later on further tests. Further tests for the subscapularis include the bear hug test. The patient puts his arm on the other shoulder and the examiner tries to lift his arm away from the shoulder. This will be painful. The belly press test or Napoleon test, the patient puts his arm on his belly, pushes hard. In a positive test, the elbow will fall backwards. And lastly, the lift-off test, the patient puts his arm behind his back, try to push the examiner's arm, which will be weak in cases of subscap tears. The supraspinatus, which is the most common muscle to be affected, we have the empty can test or the Job test. We put the arm in internal rotation with forward and abduction about 45 degrees in a downward position, and then the patient pushes up to resist against the examiner's hand. For testing the external rotation, the infraspinatus and teres minor, we put the arm in 90 degrees. We push external rotation against the examiner's hands. If there's any pain or weakness, then we might do further testing for these muscles. For the teres minor, we might do the hornblower test, in which the patient puts his arm in abduction external rotation and is unable to maintain that in a large tear, and the arm falls downwards on his mouth. We do a quick examination of all the cuff muscles, test for external rotators, internal rotators, and then we do the empty can or Job test for the supraspinatus. If any of these tests are positive, weakness or pain, then we do more specialized tests for them. Testing for AC joint pathology will mainly depend on local tenderness on the AC joint. We're also able to do the scarf test. The patient puts his arm on the other shoulder, and then we push against the elbow to squeeze the AC joint and elicit pain. Testing for the biceps tendon, we have initially the local tenderness, which indicates local tendinitis of the biceps tendon, followed by the speed test, which is resisted forward flexion of the shoulder. We also do the Yergeson test, which is resisted supination of the shoulder. As we know, the biceps is a forward flexor and a powerful supinator of the elbow. For slap lesions, we do the O'Brien test, which is flexion to 90 degrees, adduction about 10 to 20 degrees, and then we push up, there's no pain. Once we do full internal rotation to squeeze the biceps tendon and then the patient pushes up, then he gets deep-seated pain in the shoulder. We're able to do the crank test also, which is after stabilizing the scapula, we do abduction 90 degrees, we do axial pressure, and we try to move external internal rotation, which may elicit a click as you are squeezing the labrum. We have the biceps load test, in which the patient is lying down, the arm is brought into 120 degrees of abduction, and then we hold the patient's arm and we ask him to put his arm on his head against resistance. This will elicit deep-seated pain. The Said modification of this test is we bring the arm to 120 degrees of abduction with full external rotation of the arm, and then we move the elbow towards the abdomen of the patient while maintaining the same position. Again, this elicits deep pain in the shoulder in cases of slap lesion. Testing for shoulder instability and labral lesions. We have the load and shift test. While the patient is seated, we do the anterior and posterior drawer of the shoulder. This, in cases of lax patients, you'll feel the mobility of the head of the humerus much higher than normal cases. The jerk test, in cases of posterior instability, we do flexion, adduction, internal rotation, we stabilize the scapula, and we try to dislocate or sublux the shoulder posteriorly. The most important is the apprehension and relocation test for anterior instability. Patient is lying down, shoulder abducted to 90 degrees, and then we gradually do external rotation slowly till the patient feels apprehensive and he feels the shoulder subluxing. Once that happens, we actually support the shoulder by the relocation. We push the humeral head posteriorly against the table to stabilize it, and then we do the same test again like the apprehension. Usually the patient feels safer and he's able to reach a much higher external rotation range. Another important is to test for GERD, glenohumeral internal rotation deficiency, very common in overhead athletes. The patient is lying down, we stabilize the scapula, and then we look at the internal rotation range of the shoulder and we compare it to the other side. In cases of GERD, this internal rotation range will be less and his external rotation will be higher than the other side.